very excited to introduce the next session. We're not only going to have a great discussion about how to pay for Medicare for All, but also the unveiling, the launching of a wonderful paper, which is by far the best and deepest dive ever written on this subject. It's a compelling analysis, and we're going to learn about it in just a moment. Let me say one quick thing about this topic. How to pay for Medicare for all? Are you kidding? How do you pay for a system that is twice the cost, almost 19% of GDP, bankrupting businesses, putting a huge hole in government spending, of course, bankrupting households? We have the most overpriced, inequitable, and inefficient system in the world. We're wasting hundreds of billions of dollars. We spend far more than any other high-income country and get less for it. So the issue cannot be how do you pay for something that is cheaper, more efficient, and more fair. Now you're going to hear the precise answer to that in 100 pages of analysis. And so let me ask Michael Lighty to come up. You're going to be moderating. And Michael, of course, has been a leader in campaigning for social justice and Medicare for all for many, many years, is a Sanders Institute Fellow, and lead author with several authors of the report, Bob Pollin of University of Massachusetts. This will be exciting. Thank you.
Thank you, Jeff. What could be more exciting about financing Medicare for All? I want to first thank Jane Sanders and Dave Driscoll for not only this extraordinary event, but a home for this issue and this intensive policy work at the Sanders Institute on Medicare for All. So thank you so much. A shout out to Roseanne DeMauro, who is actually responsible for whatever I've done, although she wouldn't put it that way, on this Medicare for All issue. So thank you so much, Roseanne. And commissioned the study that we're going to be talking about today. So whenever I talk about Medicare for All, it's always what's covered, who's covered, comes down to how do you pay for it? It's always the question, what's it going to cost? What will it cost me and my business? Won't it bankrupt Medicare or the federal budget? All these things get out there, and yet it just distorts the policy debate. And now, thankfully, to Robert Pollin and his research team at the Political Economy Research Institute, we have answers and some compelling responses. Today, just as we're doing this panel, we're releasing this independent economic analysis of the Medicare for All Act of 2017. Robert Pollin is the principal author, and the study is our topic today. It's a comprehensive study, and it conducts an exhaustive literature review to inform your analysis of healthcare spending, and addresses these important topics: universal health care and health outcomes, demand increases and costs of universal health care, cost-saving potential under Medicare for All, and you'll notice a lot of the other studies don't do that, financing Medicare for All, budgetary impacts on businesses and families, the transition into Medicare for All, and the microeconomic impacts of Medicare. Macro, I should say, macro. That's right, thank you. That's why we have an economist here. And then you've also got 7 appendices on that review other studies, recent studies, background on methodology, data sources, and references on the key issues in the study. And it was an independent, peer-reviewed project that engaged a number of high-profile reviewers, one of which was Jeffrey Sachs, who you've heard from. Also, Donald Berwick, former administrator of the Center for Medicare and Medicaid. And also, you had Medicare for All experts like David Himmelstein, Steffi Woolhandler, and Adam Gaffney, and Ted Marmer, and economists Richard Friedman, William Shao, James Kahn, Thomas Rice, and of course, Jeffrey Sachs. And it was really one of the key pivotal studies was the one done here in Vermont by William Shao from Harvard, who proved that you could actually develop a state single-payer plan. And he reviewed your study. That's right. Let's hear it for a shout out for Vermont. So in William Shao's review of your study, and he's designed many universal healthcare systems around the world, he says, the study Economic Analysis of Medicare for All by Professor Robert Pollin and his co-authors at the University of Massachusetts Amherst present an objective, unbiased, comprehensive, and thorough economic analysis of Medicare for All. Professor Pollin and his co-authors have set a new high standard for transparency and clarity in presenting their analyses, estimations, and conclusions. The research methods they used to estimate both the cost increases and the savings are sound. The assumptions they use to generate cost estimations are based on the latest empirical evidence. Consequently, William Shao says, the conclusions of this study on the overall cost and savings of Medicare for All are reasonable and scientifically sound. That sounds good. Remarking on this approach and methodology and the significance of the study, another reviewer, Alison Galvani of the Yale School of Public Health, said, this stellar economic analysis of a single-payer universal healthcare system for the U.S. is the first to sufficiently document each step of the calculations, enabling reproducibility of the findings. It's also the first study that thoroughly addresses the transition to and financing of a universal healthcare system for the U.S. Underlying the analysis is an interdisciplinary evidence base that has been compiled from literature spanning economics, health policy, and clinical care both within the U.S. and internationally. The methodology is sound and the assumptions are conservative with regard to their conclusions. Specifically, lower-end figures from the expert literature are used in the calculation of savings, whereas anticipated expenditures are based on the higher end of empirical distributions. So she says, despite stacking the deck against Medicare for All, this analysis convincingly demonstrates the substantial improvements in cost efficiency that could be achieved by Medicare for All. Overall, Medicare for All is expected to reduce national health expenditures. And specifically, your study shows that, and that was Galvani's review, I would add, specifically, your study shows that Senator Sanders' Medicare for All Act can provide universal coverage of every resident in the United States as the system as a whole absorbs a 12% increase in demand for health services. More people getting coverage are going to use more care, but it still realizes a 19.2% in potential cost savings overall. That and the cost of prescription drugs under your approach would be lowered by 40%. Everyone is covered with comprehensive benefits. All commercial insurance premiums, copays, and deductibles are eliminated. That's no cost sharing. And overall, we save 9.6% in costs over the present system. We really can give more and pay less. Wow, this I got to say, this must be too good to be true. Is it, Bob Pollin?
Well, first of all, thank you all very much, and I don't know that there's much for me to say here. Let's say, the last panel, I mean, we said we don't want to hear all the boring statistics. It's a moral argument, and I agree with that. So this is like 93% statistics. Jeff Sachs actually took my opening line, and I should have coordinated better with him, because I said, yeah, it's pretty simple and it's pretty easy to understand in its basics, because all you have to do is look at all the other countries, say, why aren't we doing what the other countries are doing? So that's kind of the study. So I don't know that there's much for me to say. So I will just start by acknowledging some very important people who made this happen. And the first is the National Nurses United, who recruited me into this work in the first place. And I am grateful and hugely respectful of all that they have done and all that they are doing, starting with the inspired leadership of Roseanne DeMoro, who basically set the tone. One of the great labor leaders in U.S. history, I often say that if we had 5 Roseanne DeMoros, we would be a different country right now. And we would, yeah, so, and Michael also. Michael's the one that asked me to do this for California about 2 years ago, and I said, what? Are you kidding me? And he said, no, I'm not kidding you. So I said, well, Roseanne's asking, Michael's asking, okay, I'll do it. Now, I couldn't have done it without my co-authors. And 2 of my co-authors are here, Peter Arno and Jeanette Wicks-Lim. Please stand up. Among other things, they are real pains in the ass. Because everything I wrote, they said was wrong. And I had to fix it in like 19 times after it. And they said, well, maybe. So that's how it got to be decent. But it still wasn't really that good. And then we showed it to the reviewers, including Jeff Sachs, who were also pains in the ass. And they all had like 7 pages of things that had to be fixed. Jeff had about 18 pages of things that needed to be fixed. And so we fixed them. And that took a year and a half. Anyway, that's how we ended up with this thing. So, to the basics. Yes, it's actually pretty simple, because all you have to do is look at other countries. So what we found, and I liked Alison Galvani's comment. She, by the way, is going to be here tomorrow. I told her, well, I'm speaking today, but she can't make it. But anyway, if you see her tomorrow, thank her for her also very rigorous comments. And I think she captured something that we deliberately overestimated on the cost increases. In other words, yes, this is a universal system. Everybody gets covered, no cost sharing. If you have to see a medical provider, you see them, and you don't have to worry about anything out of pocket. So, of course, people are going to utilize the system more. We want people to utilize the system more. Now, the question then is, how much is the utilization going to go up? And we review the literature on that, and I think quite extensively. And from that review of the literature, we took a high-end number, which is 12%. We say overall, utilization of the system is going to go up by 12%. That number is higher than the utilization figure that was put out by the Mercatus Institute study, the Koch brothers funded study. Their utilization increase number was 11.3%. Ours is 12. And I think, you can make an argument. We don't really know. Nobody, how can you know a $3 trillion system totally transformed? We don't know what all the behavioral responses are going to be. But anyway, we took a high-end number, 12%. Then on savings, how can you get savings out of the system? As Jeff said, no-brainer, because other countries are running their healthcare systems between other advanced economies are running their healthcare systems at between 9 and 11% of GDP. And we're running it, as Jeff said, at 18% of GDP. We should be able to get some savings. So where do we get savings? We get savings from the restructuring of administration, because we don't have these multiple private insurance companies. And that also saves time for providers. I have a very close friend, by the way, who happens to be the chief of medicine at our local hospital, Cooley Dickinson. And she reviewed the study as a practicing physician. And I said, are you going to see these savings? And she said, yeah, because, she spends 25, 30% of her time filling out forms. So yes, that goes away because we're restructuring the system. And then secondly, as Michael said, on pharmaceutical pricing. Again, a no-brainer. All you have to do is look at what other countries are paying for pharmaceuticals, for prescription drugs. And the answer is they pay half. Every single country, I mean, it's maybe 47%, 53%, 62%. On balance, it's 50% less. And that's because they bargain with the pharmaceutical companies as a block. The VA in the United States also is somewhere between 40 and 80%, depending on which study you look at. They pay that much less. So, yes, we say, and again, we took a low-end figure. In Europe, they're paying half, so we said, okay, we'll take 40%, low-end figure. Okay? Then third, on provider rates. We said Medicare, well, this is in the bill. This is in the Sanders bill. Medicare rates for all providers. And so Medicare rates are lower than what providers get from private insurance companies. They're higher than what providers get from Medicaid. On balance, we say that the rates are going to go down by 7.8%. So those are our big three sources. 9% total system savings for administration, about 6% for pharma, and about 3% on providers. On top of that, there is a huge literature which says that we have this enormously wasteful system of provision, that we are wasting a lot on unnecessary services, on fraud, and so forth. In fact, Professor Shao is an expert on the issue of waste through fraud. And he was very disappointed in me because he said we can get 5% out of reducing fraud. And I said, I believe you, but I think the number sounds too high. I'll go with 2%. So that was more or less how we got that. And overall, we added that in, and that's how we got to our 19% savings. So 19% savings, 12% increase in utilization. You add that all up, on balance, you have a system that delivers decent, high-quality health care for everybody. Nobody ever has to worry. Nobody has to go bankrupt. Nobody has to fear, like the stories we heard at the last session, about having to not be able to get care. Okay, all of that goes away, and we end up still saving a little less than 10% relative to what we pay now. That's the core of Medicare for All.
And that core really speaks to the anxiety that so many people face when dealing with healthcare, or potentially the need for healthcare of members of their family, because they essentially, through this elimination of cost sharing and guaranteeing healthcare with no barriers to care, you eliminate that anxiety. That's
right. So everybody knows they have care. And the argument is, well, okay, then everyone's going to just go to the doctor. Oh, really? I mean, like, it's so much fun. So even, I mean, actually, you know, the studies, you know, Taiwan has an excellent healthcare system, single-payer system that was designed largely by Professor Shao. And it was introduced in 1996, by the way, in less than 1 year. We'll get to that point a little later. But so they studied what happened to utilization, right? You go from a system, multiple payer system, half the people in the country had no insurance. All of a sudden you have single payer, universal coverage, very little copay. So what happens? Okay, you do get some utilization increase for non-invasive stuff, right? You know, going to the doctor and so forth. But guess what? Nobody wanted to get under the knife more. Nobody said, oh, good, I can have knee surgery now that I don't need because I can.
Who knew?
Right. So,
well, let's talk on the other side on the revenue generators, right? Because we've saved this money. We've obviously created a universal system that's more efficient. But let's also talk about the specific set of revenue generators that you have. And these are distinct from what the Senator Sanders proposed. His office put out a set of pay-fors. You've come up with a specific financing plan that creates 8% lower payroll costs for businesses because you cut their premiums for healthcare by 8%.
Right. So again, in the sense...
Let me just say also, though, that the middle-income worker saved between 2.6 and 14% of household income under your financing plan. So tell us more specifically.
Well, again, you know, at the basics, it's very, very simple, right? If you have a system in which we are saying on balance, we get 9.6% savings. That means everybody in the country, as an average, is going to spend 9.6% less. That's the simple premise. Now, of course, it gets a little more complicated than that, but we have to keep that in mind, because over and over and over again, people ask the same question: how the hell can you pay for it? You know, it's easy to pay for something that costs less than what we're spending now. But, you know, it's hard. I'm telling you, people, I get interviewed by reporters, and I tell them that. They still write the story saying, oh, taxes are going to go up. We were struggling with, myself and my co-authors, Jeanette, we were struggling with how can we convey this simple idea. So the first thing we said is, let's just say, whatever businesses are paying in premiums today, the day after Medicare for All comes in, they all pay 8% less, period. Okay? So you can't get confused about that. And you're paying a premium, whatever it is. If you're paying $100 premium, the business, tomorrow you're going to pay $92. That's it. Now, that's our starting point, and yes, it does get a little more complicated, and I won't go through all the complications, but some obvious things. There are a lot of businesses that don't cover their workers at all. So what happens to them? They have to start paying. Secondly, some businesses provide very good care for their employees and some don't. And so do we want to reify, have that be a permanent thing? No. So we transition. We have that for 2 to 3 years because we want to make the point, and we also want to make the transition easy. So there's nothing complicated to start out. Whatever you're paying, if you're paying $100 now, you pay $92 tomorrow. And then in 3 years, we'll switch to something else. So we either talk about a gross receipts tax or a payroll tax. That's for business. And that's going to cover about 60% of the total coverage that we need beyond what the public sector is already paying. So we're talking about a $3 trillion system. The public sector is already paying 60%. Okay? All of this through Medicare, Medicaid, the VA, Defense Department, and the tax subsidies, which go mainly to rich people, is already paying for 60% of all health care. So all we really have to do is how to figure out how to pay the other 40%. And this essentially switching the private businesses from what they're doing now and saying, if you're paying $100 today, it's $92 tomorrow. That'll get us over $600 billion. Okay. Then we say we have a sales tax of 3.75%, but we say that's only on non-necessities. Necessities are totally exempt. And of course, we know lower income people spend a higher proportion of their income on necessities. So by exempting all necessities, you make it progressive. On top of that, for truly low-income people that are on Medicaid now, we have a tax credit. So they absolutely will not spend 1 penny more than they're paying. So as Michael said, what we end up is that households, the biggest winners in this system are the middle-class households. Especially if people are paying either out of pocket or through an individual health insurance program now. We have them saving 14% of income. In other words, their income goes up effectively by 14% through the establishment of Medicare for All.
So that's a very important point. I mean, that's a raise we can live with, and it improves the material conditions of working people. We don't talk enough about that when we talk about Medicare for All. What it means to working people to get that kind of raise, to have that kind of security and improvement in their material condition is profoundly egalitarian, ultimately. And so I kind of like to call the study a reality check, because we basically guaranteed health care for all through single-payer financing, covers everybody. It confounds, what you just said is it confounds convention, because it turns out it's cheaper and more efficient to pay for health care through the government than through private payers. Oh, wow. Yeah. You mean the market isn't the panacea when it comes to health care, right?
Well, I mean, we don't have a free market system now. right? As I just said, 60% of the money is already coming through the government.
That's right.
It's just that we are subsidizing private health insurance companies, as was emphasized in the last panel. So we have nothing resembling a free market system. We have a mixed private-public system in which private health insurance companies, private pharmaceuticals are ripping off gigantic trillion-dollar profits.
Right, and their profits derive in part from tax subsidies, which the study points out goes to the wealthy because the big tax subsidies are the exemption of these health benefits from payroll taxes.
So yes, among the boring statistics that you can find on page 97 and footnote 18, when you actually cost out what high-income people pay in healthcare now, incorporating the tax subsidy that they get, guess how much they pay? Nothing. They actually get a subsidy. And Jeanette, you tell me if I'm wrong here, because Jeanette did all the calculations. I think I'm right, and she will definitely tell me if I'm wrong. No, so for people in the top 10%, they get a subsidy of 1/10 of 1% of income, but the richest people get almost a 1% subsidy. They are paying nothing and getting money back from the government because they have high quality, high expensive health insurance.
And so now under your approach, they're going to actually pay more, still less as a percentage of income, but still they're going to pay more, which is again egalitarian.
So they're going to pay the 3.75% sales tax, but we also propose that there be a wealth tax of 0.38%, which would reduce their average rate of return on their portfolios from about 5.7% to 5.5%. They can live with that. And then we treat the long-term capital gains in the way that we now treat short-term capital gains. That raised about $70 billion. So high-income people will go from getting a subsidy to paying about 4% of their total income under Medicare for All. There are other proposals, and Jeff, among others, correctly has asked us to emphasize that our proposals are just proposals. They aren't the only ones. The Sanders office came up with others, which are quite useful to study also, and there may be better ones. So if you've got a better one, go for it.
And we'll give you the opportunity to share that later. So let's talk about transition, because the other key question is how do we get there, right? And as you point out, there are key transition questions. How do people get enrolled? Does everyone keep their current doctor? That's a big deal. Is the 4-year phase-in program optimal as the bill lays out, or is a shorter one possible? So can you talk some about those?
So the bill, and actually Bernie Sanders talked about it, I think, last night briefly. In year 1, we go down from people 65 to 55, then year 2, 45, and so forth. And there's a lot of merit to that. Obviously, you have a $3 trillion system, 18% of GDP. The notion of transforming it overnight is daunting. And you saw what happened with the Affordable Care Act, that the original sign-ups, the website crashed, and so forth. So these things will happen. So 4-year sign-up has the merit of doing things incrementally. On the other hand, it also creates problems, and I think it's fair to recognize these, and I would suggest we also consider an alternative. So the biggest problem is, we are telling the big private insurance companies that we're putting them out of business. And then we say, and by the way...
That's an applause line.
We are putting you out of business, but we want you to stay in business for 4 more years and do everything really well for your customers, even better than you have the last 90 years. It's probably not going to work out very well. So that is a very serious problem. Now, if we go to a shorter transition, yes, there will be other transition problems, like everything moving so fast. But let's think about, there's a couple of points that I think are meaningful here. If we count all the people that are covered now by businesses and all the people that are covered by the private sector, we're already at 85% of the population. Okay? So all the people that are covered by private businesses already shop around from one healthcare system, one plan to another. 15% change every year, as it is. 25, 30% shop around every year. So what we're saying is, okay, to the private businesses, you just move everybody to Medicare for all, just like you would if you're moving them to a private, another private insurance company. You move them all, and by the way, the day you do that, your health care premiums are going to go down from $100 to $92. So there's a big incentive. You do that, and then you are done. You don't have to do anything else. And we've moved everybody in one day. And secondly, all the people that are already on public plans, we're basically just shifting the accounting. So we've already got 85% of the country covered in one day. On top of that, who it wouldn't be covered? Well, the people that are on individual plans, the people that are going to get the 14% savings, yes, they would have to move. And we say, okay, look, worst case scenario, they haven't heard about it, they think it's too complicated. The next time they go to a provider, their provider just shifts them into the plan. And then we have the uninsured, which is 9%. And we want to obviously encourage them to get in. So I think a short-term transition is at least something to think about. And I mentioned it briefly. Taiwan did do it in less than a year. And yes, there was some disruptions, but within a year, a poll said, 70% of the population was satisfied. And they did it, 20 years ago without all the IT advantages that we have now. And when we introduced Medicare in the United States in 1965, 1 year. And yes, of course, there were transition problems. But again, and I'm not even saying this is necessarily right. And I know Jeff doesn't agree with me. And he made some good points in reviewing our study. But at least it's worth thinking about and recognizing the difference.
Right, but as soon as it happens, what you're also saying is the businesses are out of the healthcare business. Yeah, well, right? Other businesses, right?
Yes, they're going to pay $600 billion through this premium reduction, but they don't have to do any administration. Right. And one of the things we did also look at is how much time do they spend on administration, and how much do they cost? And if you read page 116, footnote 92, you can look at the study and you say, well, some of the businesses are actually getting savings above 8%, even though we say it's a premium reduction in 8%. And after a while, even I forgot, how are they getting more than 8%? So I had to reread it, and the reason is because we estimated their administrative costs, and they're saving on administrative costs. So on top, those administrative costs are meaningful. It's wasteful, but they have to do it, and they're done. They're totally done.
And that's what's remarkable, because we talk, as we've known for a while, since Uwe Reinhardt's work on the prices of healthcare, that prices drive so much of the cost increases. And yet you're also showing that it's administration that achieves the biggest savings from this transition. And we've shown that the transition can happen, because that's also a big question we get. But because those administrative savings come from the elimination of private health insurance and these savings in health services, there are going to be jobs lost, displacement. So how do we deal with the worker transition then?
So yes, and I think everyone here needs to recognize this and take it seriously. Because we all say there's big, big savings, which there are big savings. But let's be real. The biggest source of savings is we're going to run a much more efficient system that is not going to require all the people doing administration. Okay? And that means their jobs are going to be lost. Pause, absorb it, recognize it, deal with it. To my knowledge, we're the first study that ever tried to deal with it. And so we have a big section on just transition for people in the health insurance industry and people in the provider offices that deal with health insurance. And that's almost 2 million people by our estimate. And again, Jeanette did the estimate, so I know it's right. So it's 1.8 million people. So how do we deal with these people? Basically, we propose 4 things. The first, and actually the most important, is guaranteeing people's pensions. Okay? And we wouldn't think of that normally, but that turns out to be the most important. Because look, if we're putting the insurance companies out of business, guess what they're going to try to do? Steal from their pension funds. Right?
No, say it ain't so.
No, they would never do such a thing. They would do it, and a judge would say, well, you're not supposed to do that. And they, well, the money's gone. So we have to use the power of the ERISA, the Employee Retirement Insurance, whatever
Security,
it is, to freeze the pension funds. And as we show in excruciating detail, including one of the 7 appendices, all of the major insurers' pension funds are currently solvent, so they have to stay solvent. So we insure the pension funds, and then that guarantees a glide path for workers who are older, old people like me, who are going to be near retirement, and so we say, okay, they can go into retirement, we will guarantee their pension, and if they're guarantee them 2 years of full pay, if they want to retire. And then for people that are younger, so we say that they get 100% wage insurance for a year, which is over double what we normally give in unemployment insurance in the country. Plus they get retraining support, plus they get relocation support. So those are absolutely critical features. And to the credit of the authors of the bill in the Senate, Senator Sanders and the people that work with him, they do include that. They include the just transition as a feature. Now, they don't cost it out. We costed it out. And it turns out, when we costed it out, our number was basically the same as what's in the bill. Maybe they did cost it out and didn't tell anybody. But, you know, we're looking at a percent or a percentage. We're looking at something like $120 billion, and it's spread out over however many years the transition takes place. So if the transition takes place over 4 years, that's $30 billion a year. If it takes place over 2 years, it's $60 billion a year. That has to be part of the story. So every time everybody gives a speech from now on, you have to include just transition as part of Medicare for all. That is part of the moral imperative of Medicare for all.
Right, so this, really, that is part of the reality check here. And it is such a profound contribution to all of us doing the organizing and the policy work. So just thank you all for the Peary team and your co-researchers. So we're going to open it up for audience questions. And the study is available on the Peary website, peri.umass.edu. Yeah. And on the front page there on the website, you will be able to read this. And it is very compelling, I must tell you, to some people. Yeah. So do we have mics in the audience? Folks want to ask a question of Bob Pollin? Yes.
Did you ever measure the macroeconomic effect because you're going from regressive to progressive financing because we're a consumer-driven economy, and has that been examined in your report?
Briefly, yes. There's a lot of macroeconomic benefits moving from a more unequal society to a more equal society, in addition to the moral benefits. In macroeconomic terms, moving to a more equal society generally will promote, generally, not always, generally will promote higher levels of growth because the less wealthy consumers will spend a higher share of their income and not put it into Wall Street and encourage speculation. So that is one of the benefits through increased equality. They're also just having increased equality and having people having good access to care means that they're going to be higher productivity in individuals. Not that, I mean, that's not why we're doing it. That we're going to be like better workers fighting for, but no, it's true. You know, there'll be less people, less days lost, and less anxiety, less bankruptcies. So that will serve as a macro stabilizer, and also critically, you must have the just transition piece, because if you don't, that will be a macro destabilizer. If, you know, 1.8 million people are going to lose their jobs that will destabilize the macroeconomy. So just for the same reason that unemployment insurance in general is a macro stabilizer. All forms of unemployment insurance are macro stabilizer because it prevents people from, collapsing their standard of living and facing inordinate debts and so forth. So for that reason, the just transition turns out to be a significant macro stabilizer.
All right, another question?
Hi, this is just phenomenal. I'm so excited with all these numbers. It's great ammunition for us. I wondered if you could talk a little bit about how the money that goes to paying for Medicare for All gets preserved from conservatives and policymakers who want to take that money and say that we're in a deficit and it's contributing to the deficit. So with Social Security, we have a trust fund, and we can actually say, wait a second, Social Security does not contribute to the deficit. The money is set aside. Will we be able to do that with the scenario that you're talking about?
Well, first of all, I forgot to mention that the way we also proposed the financing, we actually build in a surplus in the system. So when I talked about the various tax schemes, those get us to a 1% surplus. So the system, as we've designed it, is running every year at a 1% surplus. So it's not like we're like at a knife's edge trying to say, where do we come up with that last penny? So we're assuming that we need to raise $105 billion in addition to the 1.9 trillion, in addition to the 1.9 trillion that's already in the public expenditure. So we need 1.05 trillion additional. We raise 1.08, so we get a 1% surplus. Now, what you're raising is, do we set, you remember, I think Al Gore used to talk about the lockbox all the time for Social Security. Well, you're proposing the equivalent. And yes, I mean, we do talk about global budgeting and so forth. We do not talk about the lockbox idea per se. And in that sense, by the way, I want to acknowledge, if you read the reviewers' comments that are on our website as well, there are critical points, right? Of course, no, not everyone's going to agree with everything, and there are deficiencies in the study, and I acknowledge them. We didn't cover everything. Donald Berwick, who I respect a lot, I've never met him, but he really worked hard in reviewing our study, and he actually proposed something what you're saying. And he's saying, it's a shame, Bob, that you didn't put that in the study. Fair enough. So when you write your next paper, and you say that this Perry study forgot to talk about this. And we did.
All right. Jamie?
One of the hospitals making less money, drug companies making less money, that's easy. We all love that. Public health, doctors making less money. Seems to be like, are they or are they not, and what's our answer? Because that has been the political force we haven't gotten this done in 30 years.
Yeah. So we spent a lot of time on that. So let's just talk it through a little bit. So if we move everybody to Medicare rates, so Medicare rates are about 25% less than private industry rates, but Medicare rates are about 10% more than Medicaid rates. So we blend it all together, and on average, we estimate that the providers per visit will have 7% less, okay? But that doesn't mean they're going to make 7% less income. Why? Well, we also, as you know, we said they're going to spend, we are going to release providers from spending a whole lot of time on administration. For example, my friend at Cooley Dickinson Hospital in Northampton, who told me, yeah, she spends 25% filling out forms. Now, she's still going to fill out forms. But we did, I think, a pretty thorough estimate of how much less they're going to get to fill out forms. And for physicians, we said they're going to save 4 hours a week. And those 4 hours can go to treatment, which, by the way, means that the people get better care, and you get to see your provider. It also means that they can make more money. These are billable hours. So while their rates go down by 7%, they get something like an 8% increase in their share of billable hours. So and there's different studies. We review another study that was done by the Urban Institute, who used a totally different methodology. And their estimate is, if you go to Medicare rates for all, it's 9% less. Ours was 7% less. So they're convergent. In any case, roughly speaking, if you say billable hours are going to go up 8%, the how much you get paid per billable hour is going to go down by 7% or 9%. In other words, the average physician comes out the same. Now, we know that averages are misleading. So what really happens when we break it down by specialty and subspecialty? Well, primary care doctors, emergency room doctors, these are people that are, and it's in the study, are at the low end of the physician pay scale. They are actually going to go up. They're going to make more money. Who's going to make less money? The highest paid specialists, radiologists. Yeah, actually not so much cardiologists, as it turns out. Neurosurgeons. They are going to make 10 or 15% less. But as we show, if you do a comparison, and Jeff inspired this, so we owe Jeff because he really pounded on it. If you can do a comparison with other advanced economies, what are the specialists in Germany, specialists in the UK? They're making 30 or 40, 50% less than ours are now. And the specialists, they're making $400,000 to $500,000 as it is on average. So instead of making 500, they're going to make 470. Yeah, boo-hoo. So that is part of the story. On top of that, we do also suggest, and this comes from Professor Reinhardt's work, who was one of the greatest healthcare economists in the country, who passed away a year ago. And he did a study on this issue of what we call net present value, fancy techo term, net present value of a career as a physician, including indebtedness, and then your income. And so, of course, all the doctors are still coming out just fine, even with their student debt. But what he also then suggested is, well, we might want to, it's not rational for people to have to be piled on all this debt. Why can't we make medical school cheaper? He said, well, one of the big factors in medical school, actually, is that the medical students are subsidizing the professor's research. Because the professors, I forget his exact hours, but professors aren't hanging around with the students a whole heck of a lot. They're spending a lot of time on their research, and the students are paying for it through taking on the debt. So he proposes, as one of his suggestions, that we fund medical research in a more rational way. And then we lower student debt, and so that even the radiologists and neurosurgeons are going to come out just fine, even under Medicare for all.
All right. I want to give anyone back here, because I know we've got theater in the round here. Anyone back here have a question? Oh, okay. Go ahead. Oh, someone's got a mic, and then John? Okay.
Very
all right, go ahead.
Could you talk for a moment about the stitch in time saves time phenomenon, where under Medicare for all, people would be more likely to go in early and get a cheap fix rather than wait and then end up paying a more expensive fix?
Yeah, that's actually, yeah. Thank you for bringing that up. That's very important. Because when we actually look at the profile of people, everybody in the country, so there's roughly 9% of us are uninsured. But roughly, nearly 30% of us are what we call underinsured. So what does it mean to be underinsured? Well, you have health insurance, but it is not adequate, so that people don't want to go into, these are like the stories we heard in the last session. They don't want to go in because it costs too much. That's basically it. So they don't go in, and then their health conditions are exacerbated. And so then they wait till they need surgery, and you have to spend $25,000 in surgery as opposed to spending, $80 for a visit. So that is a big source of savings. And We didn't cost that out, but that's built into the system.
All right, John, you had a question?
Well, Trump gave, I think, $1 trillion to the Koch brothers and Walmart. And I think that's 1,000 billion. So wouldn't that be something you could use to pay?
Take the corporate tax
Well, yeah,
break back.
but
yeah.
even within that, I wondered, one question was, how many jobs do you think you would actually lose in the just transition? And would those perhaps get, would there be new jobs in a Green New Deal? And then the other thing would be, have you thought about military spending? Because you've talked about healthcare as GDP. Even if you cut military spending by 5% or anything like that, have there been any discussions about that kind of a movement?
Yeah. So thank you for the question. It so happens I have also done research around the Green New Deal and the job part of the Green New Deal. I've also done research on the military spending and jobs. Once you get rolling with these boring statistical models, it gets fun and you just keep going. How many jobs are going to get lost? There's 800,000 people employed in the private health insurance industry. So we're saying all of them, they're all gone. There's about 1 million people employed at the level of providers doing the clerical work, the administrative work. Now, some of them, those jobs are going to be retained. No, actually, where's Jeanette? So it's 1 million jobs are going to be lost, right? So it's 1.4 million. So we're saying basically 35% of the jobs are going to be retained, 65% lost. So overall, it's roughly 1.2 million jobs. So where do the jobs come from? Well, 1.2 million jobs in a growth economy is a challenge, but actually it's not that big of a challenge. We have 160 million jobs in the economy. So, the economy grows, 1 million jobs get created. But as you're saying, it's also true that, yes, our transition out of fossil fuels to a green economy is a big source of job creation. In separate work, and we'll be talking about it myself. Tomorrow we have a panel on green transition in Puerto Rico, which is one of the countries and regions I've looked at. But in general in the U.S., we think the transition to a green economy is going to create about 4 million jobs. So that is now it's true that you're going to lose for coal miners and so forth, but so that will be a source of job creation. Military spending. So what's often argued about military spending, we can't cut military spending regardless of what you think about our foreign policy. We can't cut it because it's good for jobs. That's an argument that's frequently made. Every time you spend $1 on anything in this or any other economy, it's good for jobs. Anything creates jobs. So the relevant question is not whether something creates jobs, how many jobs relative to some other activity. So in this U.S. economy, military spending creates about 1 million jobs per dollar of expenditure. Take a comparison, education. Education generates 23 jobs per dollar of expenditure. So if we shift out of military...
Bob, can you repeat the military number of jobs created?
About 11 jobs.
Yeah.
Job creation per dollar of, if you spend $1 million in the military, you'll create 11 jobs. If you spend $1 million in education, you'll create 23 jobs on average. Yeah. So yes, if we shift out of military spending into other activities, you can create more jobs. If we take the average, if we shift out of the military and then just spend it all on everything in general, you're going to go from 11 jobs to about 14 jobs. So there's a lot of ways to make up for those gaps.
And Bob, you have job retraining funds as part of the worker transition program.
Yes,
right.
We have job retraining.
Yeah.
And again, I just want to say it, I already said it, we proponents of Medicare for All have to move this to the top of the agenda as part of the story. And hopefully that begins today, because it hasn't been, And whether you think it's a moral issue or not, as a political issue, we're very vulnerable on this. Because anyone can say, oh, you guys, yeah, you want to help everybody, but how come you don't care about the people in the health insurance industry? Well, we can say we do.
Exactly. Everybody gets care.
Yeah.
Everybody's taken care of,
Yeah.
including the workers in the industry.
Yes.
Just an extraordinary study. Bob, thank you for the Peary team. We're going to wrap it up at this point, and we encourage folks to talk with you individually, or I encourage them to talk to you individually.
I'm around.
All right. So thank you all.
And we at the Sanders Institute want to thank Bob Pollin, Michael Lighty, and also Jeffrey Sachs, who's been working on a lot of this budget issues that I think we all need to pay a lot more attention to and communicate about. We are now serving lunch in the atrium. This is the room that you had coffee and breakfast in this morning, and we will reconvene with a panel on the climate crisis and what a Green New Deal would look like just after 1.